Good morning, guys. Thank you so much for having me. It's a pleasure to be here, and thank you to Dr. Lund for setting this up and reaching out. And just a quick show of hands. How many of you guys have heard of interventional radiology? Or okay, good. All right, this will be interesting then. So this might be slightly advanced, but just like everything, we're going to start from the beginning and talk about its evolution initially and move on from there, okay? And feel free to stop with questions if you have some. Just let me know if there's, if I'm going too fast or anything's, you want to go over anything else. So this is kind of where it starts. This is Dr. Seldinger. Who, prior to him, it was thought that all of this was kind of madness a little bit. So basically, everything we do in interventional radiology is based on his technique, which is basically puncturing any kind of cavity, vessel in the body, and then dilating up to gain access into that cavity or blood vessel. So here you have the, let's see if I can do this. So basically these are the things that we kind of use. So this is a needle here. Sorry, right here is the needle, and this is called the dilator, and this is basically the wire. So for example, in a vessel, the femoral artery, the needle goes in first, you have blood return, the wire goes in, and then the dilator goes in. Prior to this, it was only very large bore needles that were felt to gain access into these things. Lots of injuries, lots of problems with that technique. So this basically changed everything in 1953, and it's still, you know, every time I puncture a groin, this is what we do. Then comes along Crazy Charlie. So Crazy Charlie, also known as Charles' daughter, is actually from Oregon, and he actually has a fellowship named after him. It's the Daughter Institute at the University of Oregon. 1963, he basically started introducing these catheters that he would shape himself to gain access into strange vessels or hard to get into vessels. So they would have like, I mean, I hear stories about this, I've never seen them, but they would have little like tea heater things on the side, and they would shape these plastic catheters in certain ways to gain access into vessels they know the anatomy of. But they didn't have pre-shaped catheters like we're fortunate enough to have today. So his story kind of starts with, he worked closely with the vascular surgeons, as all radiologists and interventional radiologists do, and a woman who basically would not allow herself to have an amputation. And the surgeon basically says, okay, you can try to fix this leg if you think you can. And so he, that's basically where this starts. So this is a nice quote from Dr. Daughter, and this is actually his kind of emblem that he carried with him for a long time. So if a plumber can do it to pipes, we can do it to blood vessels. And I mean, it seems very like basic, but I mean, in the end, this was actually completely true. And he was way ahead of his time, you know, in the 60s to be thinking like this. And everybody thought he was completely nuts to think that, you know, you could fix blood vessels from inside and not have these big open surgeries, and, you know, you can fix aortas from just tiny punctures in the groin rather than, you know, open the entire abdomen. So pretty interesting stuff. Let's see here.
In the mid-1900s, doctors diagnosed many diseases by injecting special dye into the blood vessels and taking moving X-rays. Most patients went on to have surgery, as there were no alternatives. Then one day, Dr. Charles Dotter had a very big idea, and it changed everything. Dotter had the radical notion that he could do more than just see the problem. Once inside the body, he could fix it. And in 1964, he did just that. An elderly woman named Laura Shaw was at risk of losing her leg, but she stubbornly refused surgery at all costs. At his wit's end, her surgeon sent Mrs. Shaw to Dr. Dotter and asked him to do whatever he could to help her. Dotter entered the artery in her leg through a pinhole, then injected dye into the blood to reveal her leg vessels under x-rays. He discovered an artery in her mid-thigh that was so tightly blocked that no blood could reach her calf and foot. Dotter's next step was truly revolutionary. He eased a wire across the blockage, then slid a plastic tube over the wire to expand the blocked artery. It worked. He opened the channel, allowing the blood to rush in and save her starved leg. Days later, Laura Shaw left the hospital on her own 2 feet. A revolution in medicine had begun. Dr. Charles Dotter had every reason to be elated. By applying a bit of know-how straight out of the plumber's manual, he had just spared his patient the necessity of losing a leg.
Charles Dotter was a great innovator. He just saw into the future the way other people didn't. He had a catheter in and thought, well, gee, if the catheter's in, I could probably fix something.
He passed it through that blockage and then pulled everything out, and voila, there was better flow. And that was a revolution. I'm going to put this thing through the artery that's blocked, and it's not going to be ruined. And the patient's not going to lose their leg. They're actually going to get better.
That whole idea was what started all of the minimally invasive procedures.
Can you do that to an artery and have the artery function?
Can we do this without cutting somebody open?
And the answer was yes.
So pretty amazing when you think about it, that he thought of this in the first place, and that he was able to treat so many people and avoid amputation. And it's still actually the major goal of interventional radiologists today is to avoid amputation, things like that. And I'll get into some of the other things we do. It's not just in the legs, but almost everywhere in the body. But again, the entire basis of every single thing we do is are these techniques, whether it's abscess drainage or ballooning veins or arteries. It's all pretty much this. So here's some major milestones in interventional radiology. It's very small, yeah. So the first, let me just highlight some of the major ones. The first embolization for pelvic trauma is 1973. The first idea for treating tumors with thermal ablation was 1980. The first TIPS, which is an very important milestone, is 1982. The first stents that we used, 1985. The first abdominal aortic stent grafts were 1990, and so forth. But anyway, we've come a long, long way since that time, but it is still kind of moving along. But today, I mean, if you think about the new things that we're coming up with today, it's moving much, much faster than this, because I think the idea that these therapies and these treatments are viable and much better than, big open surgeries and long hospital stays is now kind of generally accepted by many, many physicians. So our referral has grown quite a bit, and we're always willing to try new things and do new things, and we kind of have a past to do those things, considering all these things in the past. So you can become very innovative with this field, and that's one of the nice things about it. So what do we actually do? it's kind of hard to describe, and even when we're talking to patients, it's very hard to describe to them what kind of doctors we are or what we do. I think the major focus is that we use imaging to diagnose and treat any and everything in the body. I mean, and a lot of times it's some of the stuff that the other specialties, for whatever reason, would rather kind of not treat or do. Whether the patient is not an operative candidate, insurance issues, we're kind of always hand in hand with the hospital. So the insurance stuff, it doesn't really affect us as much as it does some other physicians in the hospital. So, but here we have a few things. So anything from pulmonology to oncology to neurology, veins, and yeah, so, and even a lot more than that actually. So that's, this is a typical interventional radiology suite. Basically, there's a table and then a moving kind of image intensifier that can angle in many directions. There's a pedal there, and basically that's where we do the majority of our interventional procedures. We also use CT and ultrasound for many of our procedures, as you'll see on these other slides. So sorry, I don't know if you guys can read that either, but I'll just go over a few of the major ones. So what we do, so vascular disease, and then within vascular disease we do many different things. So we can treat peripheral arterial disease like you've seen, treat venous disease, so all kinds of venous disease, chronic venous insufficiency, May-Thurner syndrome. We can treat varicose veins, and then DVT is also one of the hot spots that we like to treat too. Let's see, in terms of cancer, in the past like 20 years, a lot of growth in our cancer treatment options, which I'll show you a few examples of in the future, in the coming up slides. But anything from putting your port in to have your chemotherapy to actually treating the tumor itself, we do all those things. So, and we'll talk about some of those in detail. In terms of women's health, so we even do sometimes fallopian tubes will be blocked and prevent a woman from being fertile. So we do fallopian tube recanalization for infertility. We treat uterine fibroids, which can be a major cause of pain for females, pelvic congestion syndrome. And then for men, on the opposite side of that, we can treat large prostates, just basically same day procedure, you're out the same day, by puncturing the groin or wrist and embolizing the veins embolizing the arteries to the prostate. So it's pretty interesting stuff, and it seems kind of wacky, but they're all very well studied and they all work really well. And I mean, if you think about it, how much it saves both the patient and the economic burden of long hospitalizations. I mean, having either a radical prostatectomy or a TURP can be often like very debilitating, and where we'll puncture your groin, embolize the arteries, and you leave the same day. So another kind of example of something we do, I don't know if you guys remember this, where they were, I think it was in DC a couple of years ago, where they were having some charity baseball event. So this is Scalise, who basically was shot in that at that baseball game. He ended up going to this hospital in DC, MedStar, and although a lot of it is credited to the trauma surgeon, it was actually an interventional radiologist who treated him, and he was out within a few days. Basically, just going through his groin and treating an artery that was bleeding rather than opening him up. So while a trauma surgeon may have seen him and evaluated him, it was probably just a very straightforward procedure for the interventional radiologist who went in through his groin, embolized this bleeding artery, and he was able to be discharged soon after. So pretty interesting. He also actually did thank interventional radiology as well. It's Melania Trump. She even also had an embolization of a tumor in her kidney, also done by interventional radiology. Just to sort of illustrate the point that we're everywhere in every hospital, but you often just don't hear about us. It's not like an orthopedic surgeon or a urologist, or you know what you're going to see that doctor for. I mean, you can honestly see us for almost anything. So it's an interesting specialty. This is just an article that kind of highlights that point. Interventional radiology as a specialty does not receive the same appreciation in the general public or media that other specialties receive, and it's hard to get the point across sometimes, or for even people to understand what you do in the end. So here are some of the things again. We'll go over them in more detail about the things we do. Vascular, we do a bunch of arterial stuff, we do venous stuff, we do dialysis work. Oncology is a very big field for interventional radiologists. We treat tumors of the liver, the kidney, the lungs, and even bone tumors. We do the majority of biopsies in the hospital, so anytime somebody has a biopsy, we do majority of drainages in the hospital, anytime somebody has a drainage. And then we do some musculoskeletal interventions as well. And then we do pretty much most of the venous access, or almost any access in the entire hospital. If anybody has a difficult time accessing a vein or artery, they call us and we come help them out, or we'll just take over the patient and do it ourselves. So I just want to talk about oncology for just a brief few minutes. So we have curative treatments for a lot of tumors. So ablation is, we have 3 types of ablation techniques, pretty much. There are more, but major ones. So microwave ablation, which relies on heat, radiofrequency ablation, which relies on heat, and then cryoablation, which actually freezes tumors. And we do all of those. And then we also have treatments for tumors where we'll actually go through the groin into the artery itself, right next to the tumor, and put chemotherapy directly into the tumor via the artery supplying that tumor to basically, chemotherapy can be debilitating if you're having it, just through your veins. This is a more delicate way to treat these tumors. They get targeted chemotherapy right to the lesion. So it's kind of a nicer way to treat tumors. And we'll go through some of those too. So this is an example of ablation. So basically we typically do them with ultrasound and CT. We have these probes that basically the end of them heat or freeze if you're going to do cryoablation. So the idea is to get the needle directly into the tumor itself, and then you just turn the machine on and it cooks the tumor. So, or freezes it. So this is an example of radiofrequency ablation, and you can see here the needle entering the liver, and you can see there's a mass there in the liver, and after it's done, it's kind of like it shows up as kind of like a black spot that has no more enhancement or anything, and the tumor has been successfully treated. So, I mean, these things used to require big liver resections and stuff like that, and now we send them home the same day. So, pretty cool. This is the transarterial chemoembolization, which, you know, we're doing pretty often. So this is where we enter the groin. You can see that this is a hepatocellular carcinoma where the tumor is very vascular and supplied by these blood vessels. So we get these little beads that are actually filled with chemotherapy or attached to chemotherapy. Typically it's doxorubicin, and we'll get right next to that tumor and embolize the tumor. And then you can see that the follow-up picture after we're done embolizing, there's no more, there's no like spotted lesion there that you can see really. So, yeah.
Could you define for us embolization?
So yeah, that's a great question. So embolization is, so it's kind of a vague term for cutting off the blood supply to something. So there's trauma embolization, like you saw with the Senator Scalise. That's like an example of trauma embolization. And there's many, many, many different kinds of embolic materials. So for these, we use little tiny beads which have chemo attached to them. We also use this stuff called gel foam, which you can cut up and make into a slurry while you're sitting there on the table, while the patient's on the table, and you mix it with some saline, and that's called gel foam embolization. It tends to be less aggressive, but sometimes you want a delicate touch because, you know, ultimately you're killing off the blood supply to these vessels, so it's a delicate balance between embolizing what you want to be embolized and tissue ischemia, where if you embolize that vessel too much, then the other organs adjacent to it can also be harmed. So, so beads, gel foam, coils. We have coils that are 6 feet long. You can, eventually they end up this big, but they're tiny, tiny microcoils that you're putting in, and they're extremely long, but they're used to cut off an artery and end up being tiny by the time they enter the body. Those are the main types. We have glue also. It's not like Elmer's glue, but it's a very expensive glue. I think it's like $5,000 for like the tiniest vial. And we can put that through the catheter and embolize things. And another thing they use in the brain very commonly is something called onyx, which is a polymer that gets very dense and can cut off the blood supply. So many, many different types of embolization for many different reasons, and also many different tools you can use to embolize things. So the question is whether these patients arrive to us or are referred to us via oncologists, or they come to us by finding out about us in some other way. That is a great question. It's typically some of both, but mostly via the oncologist. So times we'll have a discussion in tumor board or something like that, and we'll say this is a good candidate for chemoembolization, good candidate for ablation, stuff like that. So, but people, oftentimes patients are very smart now. They'll just like go on the internet, look us up, and they'll show up and say, I want my tumor embolized, or I mean, and then we actually will send them back to the oncologist and come back like, okay, you need chemo planning, stuff like that. We're not their primary doctor, and people often forget that. They want us to be their primary doctor, but we should take more ownership of our patients, but and we try to as much as we can, but I mean, we're just doing like 20, 30 procedures a day. It can be very difficult to follow these people over time. But yeah, and they also need a long-term plan, and they want to talk to somebody about stuff. But yeah, it happens both ways, I think, but predominantly through our oncologists. So biopsies, we do very, very difficult biopsies in the hospital, things that you would have to have surgery before. So up there is a retroperitoneal lymph node biopsy right by the aorta. And nowadays it's very easy for us to do these biopsies, whereas in the past it was very difficult. And here, a lung, we can do lung ablations. So before, these would be big surgeries. You have pneumothoraces, and you stay in the hospital for long periods of time. Now we can stick a cryo probe or a microwave probe directly into the lesion and treat it right away. So, and they can leave the same day. So it's pretty interesting. We also biopsy all these things too. So. I'll try to speed up a little bit. So we'll talk a little bit about peripheral arterial disease and the kind of things we do. So limb salvage is paramount to us. So we don't want people losing their limbs. Amputation should be a thing of the past. We can open up many, many, many vessels in the lower extremity, and we can keep opening them up. So yeah, there's like this no amputation fight going around in interventional radiology. The vascular surgeons have not caught on completely yet, but they're getting there. Sometimes it's easy to amputate rather than deal with the issue, but a lot of these people are very complex cases, but if you have the time and you put in the effort, you can actually save people's limbs quite often, and it's very gratifying. So the question is what is peripheral arterial disease? So peripheral arterial disease is basically, it's atherosclerotic disease, which is the most common disease in everybody, I guess. So let's say, take the heart, for example, because it's a very common thing to talk about. So when you have a coronary angiogram, so in a child, their arteries have nothing in them. Like, they're very clean and pure and they're young. But in adults or older people, through the years, whether it's genetics or a combination of smoking, or you get these micro injuries to the blood vessel, which over time will cause what's called atherosclerosis. So plaques will form on the vessels, inside the vessel wall, on the vessel wall, and kind of narrow that vessel. So eventually, if that vessel completely shuts down from this narrowing or slows, then that's when you have to fix something. So it's the same in the heart as it is in the brain, as it is in the legs, as it is, in the abdominal aorta. This is all caused by smoking, diabetes, genetic factors, all these things over time just injuring the vessel. And eventually it comes to this point where they have not a single blood vessel going to their foot. So here's an example of some peripheral arterial disease. So you can see here, this vessel, there should be a vessel coming completely down here. And this is completely occluded. So, and here's lower down. So what we do is basically puncture your groin, get into this vessel, which is completely occluded, and then you can put a stent in there. So you can see, you kind of barely see the stent coming down here. And then you can see the blood flow is completely reestablished down here. So, and then here, and then they have blood flow to their foot, which is the most important thing. Here's another thing. So basically, this is a non-healing ulcer, and you can see that it's already, this patient's already had an amputation, and they have a non-healing ulcer here. You can see this blood vessel here, which is the posterior tibial artery, is kind of okay and coming around, but then there should be, in most people, what's called the anterior tibial artery and coming around here. And that's why this isn't healing, because you can see there's an absence of blood flow here. Once we're able to get in and angioplasty, but just a small, tiny balloon, we put it in the artery. Once we cross it, we're able to reestablish flow into this area and help heal the wound, which will not heal. So you're almost like making these new blood vessels come back. So, okay, so the question is, what are the potential risks of, so this particular procedure, so when I'm crossing a vessel which is completely down and doesn't really exist in that patient anymore, very low potential risk, very low potential downside. It's almost for free, right? Because this vessel doesn't exist. So I'm in it, and I'm trying to reestablish flow within it. If it doesn't work, it doesn't work. The patient doesn't get any worse. If it works, they're going to heal their wound. They're not going to have an amputation. Life is going to be much better. But that being said, when we're doing peripheral angioplasty and stuff like that in general, you always risk injuring the major vessel when you're coming down it. So you have to be very careful. Because if, for example, if I'm coming, so this is in the foot, but the way I get there is through the groin. So this vessel here is being supplied by the major vessel I'm in the thigh, and then in the knee, and then in the leg. So if I injure that vessel, then she's going to have no flow down here in her foot. Then it's going to be a worse amputation. But like I said, the catheter techniques have become so good that we rarely injure the parent vessel that's supplying these things. So I can get into the vessel that doesn't exist anymore pretty easily without hurting the vessel that is supplying this part of the foot. So, yeah. But you can see here, basically we crossed the lesion. You can see the very multiple areas of tight narrowing. There is a stent in here, but it's very hard to see and it's not projecting. But this is the superficial femoral artery right below the groin and is stented down to here. And you can see the difference between the pictures and how much more robust the blood flow will be and how much better they will be walking and moving around and also healing wounds if necessary. Okay. So here's an example of an occlusion. So one of the newer ways we're dealing with these, which is very low risk, is we're actually puncturing the foot and going up rather than the groin and going down. So this is an example of that. So we're puncturing vessels that are 2 millimeters, the tiniest blood vessels. You can see us, we're coming from the bottom up and then fixing this vessel from below and putting stents in. And they can walk out like within an hour. So, yeah. So it's very, because the biggest thing in the groin is it's the femoral artery, you know, if you move too soon. So we usually have patients lie flat for 2 hours just so that the groin heals completely, and then they can still go home. But for this, when you're puncturing a 1-2 millimeter vessel, it doesn't bleed like the femoral artery. So you can walk out as soon as we're done. So yeah, it's a very nice. So this is a woman who basically underwent coronary angiogram. So I don't know if you guys know, but a lot of cardiologists are doing coronary angiograms through the wrist. Which it's fine. I mean, it's done. I mean, thousands are probably done every day across the country, and they're probably mostly fine. But the radial artery is a more sensitive artery than the femoral artery, and can sometimes cause some issues. So this is a 65-year-old woman who had coronary angiogram through her wrist. It's not projecting well, but you can kind of see her arm is turning blue, and her fingertips are very blue, and she has pretty much no blood flow to her hand. So this is from an injury to the radial artery just for the coronary angiogram. So here you see there's a discontinuation of the radial artery where it was injured. It's completely blocked off, and there's no blood flow to her hand. Here's the injury again, and there's no blood flow to the hand. The hand is usually forgiving because there's an ulnar artery, and there's usually an arch that kind of connects in the hand, but in her case, she did not have a great connection, so her hand became ischemic as soon as the radial artery went down. So we punctured her groin, went up through the aorta, went to her hand, and basically started angioplasting here and giving some blood thinners and TPA, which will break up any blood clots. And then as soon as the vessel opened, you can see where the injury is. There's some bleeding coming out of the radial artery. And then here is the post picture where you see it's completely healed. We do one of those tiny balloons, which is 2 millimeters. We leave it up for a while, we inflate it, and that basically restores the blood flow and also heals the injury where it's bleeding out of the blood vessel. And you can see her hand is great color after. She won't lose her hand, and she did fine. So that's a lot of times interventional radiology is dealing with complications too. So it's things we see often. Other specialties do a lot of things, and sometimes we have to accept their complications and deal with them. And usually it's nice when we get a good outcome like this. So this is just an example of the aortoiliac disease and what we can do there. We can puncture the groin, and you can see this vessel here is completely occluded. This is the common iliac artery coming off the aorta. We have nice vascular stents that we can line them up with and then just fix there. So this is a good example of almost back to normal, new. Yeah. Sorry. Here's an example of trauma. So here's a splenic laceration with some bleeding. Here you see some areas of irregularity. We go through the groin. We puncture the artery that we access the artery that we know is going to be bleeding. This is the celiac artery. This is the hepatic artery. This is the splenic artery. Then you see there's some extravasation here. We can completely embolize this artery with coils, as you see here. So this is an example of coils. It's not really projecting well, and it's hard to see, but yeah. So before this used to be an open surgery, take out the spleen, there's blood everywhere, they still might not survive. Now it's a 15-minute procedure for us. So do lots of stuff with venous disease. This is an example of something called Paget-Schroeder syndrome. So these people have compression of their vein by a rib, usually. And this is venous Paget-Schroeder disease. So they have all these collaterals, and they have no flow down into their SVC, which is the major drainer from the upper extremities. And so here you see we can get access across it, and then we balloon plasty these with much bigger balloons than I was talking about in the legs. So we use 2 millimeter balloons in the legs. These balloons we have up to 24 millimeter balloons. So I mean they're like big balloons. Here's a case of an IVC filter, which was put in. We see this more and more common. People have had IVC filters for like 20 years. If any of you guys have an IVC filter, I recommend getting it taken out. Don't wait too long. What happens is IVC filters will scar the vein down very bad after a long time of being in. And you can see here, these patients always present with bilateral lower extremity swelling. They can't walk. They have clot from their ankles up to their abdomen. The entire IVC is filled with clot. So you can see here there's no blood flow beyond the IVC filter. In these cases, what we'll do is leave the IVC filter or try to take it out. This is a particularly dangerous filter to take out. There's not hundreds, but tens of different kinds of filters, maybe 20 different kinds. This one's very difficult. It can be very traumatic to take out. So a lot of times we'll just leave it in, and then we'll put a stent across it. And you can still see the IVC filter in the background, and we'll stent across it to give the patient blood return back from their legs.
And what were the filters put in for the first place?
They put filters in for DVT, and ironically, they also cause DVT in the long run. So anybody who comes in with a DVT, we're pretty much, we put them in haphazardly in the past, and everybody got a filter, and then you never followed up, and 15 years later they come back and their legs are completely swollen. They have no IVC, scars down their vein completely. So we're seeing a lot of people come back and say, oh, I had a filter put in 15 years ago, nobody took it out. We're being more aggressive about taking our filters out. It's very important to get them out. So let's see. So pelvic congestion syndrome. So just some of the other things we treat. Uterine fibroid embolization. Sometimes you can have big fibroids in your uterus, and we want to destroy the vascular supply to those things. So we'll get in with a catheter, get to the fibroid, and just embolize. Here's an example of that. Here you see these big arteries to the uterus. We get a catheter in, embolize the fibroid, get a much better result at the end. Prostate artery embolization for BPH. This is semi-new, but is gaining a lot of traction. So here we're accessing the prostate artery itself, and we're putting tiny little beads into the prostate artery, and then the prostate will shrink over time in the next couple weeks. So rather than have some big prostatectomy or TURP or anything like that, we do this, and your prostate goes down in size significantly. Pulmonary artery thrombolysis. So this is for PE. So people come in with DVT, eventually leads to PE when it passes through the veins and the IVC. But now we're treating the pulmonary artery by going into the pulmonary artery itself and sucking the clot out. So here you see a completely blocked pulmonary artery with no blush into the lungs. So this is, people die from this if they present with hypotension and stuff like that. I mean, they're pretty big pulmonary embolus. So here's the left side basically showing the same thing. There's no flow into the lungs. This is a very sticky situation. But now we can put catheters into the pulmonary artery and take the clot out, and we're done. We have great results with good blood flow into the pulmonary artery again. So future directions for interventional radiology, geniculate artery embolization for knee pain, for osteoarthritis. We're constantly trying to seek new ground and see if there's other things we can treat. So this is kind of new, and it's being studied right now. But this is basically for osteoarthritis and people who have knee pain and chronic knee pain. You can see that they have hypervascularity in the joint space itself. So somebody just decided that if we embolize this vessel, maybe we can treat some knee pain, and it actually worked. So you can see here is a good picture of a before and after. So this is what it should normally look like here. You can see there's not too much blush there. It's a normal looking knee. Then you see a lot of blush here, suggesting inflammation and can cause some chronic pain. Then here you see the patient with the abnormal vessels, and then once it's embolized, you don't see this like blushing here in the joint, and it looks pretty good. So, yeah. I think that's it. So thank you guys. Thanks. It's a pleasure talking to you guys. And yeah, I'll open it up for questions if you guys have any. Thanks so much.